Mr. Chairman, we're live.
Thank you very much. We'll call this meeting to order, Labor and Health of the Senate, excuse me, my voice is faltering this morning, so I apologize. Welcome. Once again, as always, if you have your cell phones, please leave them turned on, because if they go off, you will buy donuts for the next meeting. Okay, nobody's followed my rules yet, so continue. We have 3 bills before us today. Roll call, not needed. Senator Bouchard's having a little bit of a difficult time getting in this morning. He has a little bit more snowy roads than some of us had to deal with this morning, so he will be late. And hopefully he's safe and makes it in fine. The first bill for our consideration this morning is Senate File 8, Essential Subsidy Payments to Behavioral Health Center. This comes as a product of the behavioral remodel that we dealt with last session and part of the mental health subcommittee, excuse me. And go ahead and come on up, Director. To present this bill this morning, Director Johansson in. Franz, I understand, is home with a sick child, so if he's listening in, our thoughts are with him. For the child more than him. Yeah.
Mr. Chairman, I totally agree. Good morning, Stefan Johansson with the Department of Health. This is a pretty simple bill. It's not as simple as our famous comma bill from several years ago, but it's relatively straightforward. As you mentioned, Mr. Chairman, this is related to our ongoing behavioral health redesign, which the legislature passed into law 2 sessions ago through original House Bill 38, I think Enrolled Act 56. So we will be entering our, let's call it, 2.5 year of implementation this coming interim. I just want to mention for the committee how pleased I am with where we've gone so far, the partnership we have with our providers, with Department of Family Services and Corrections on these shared populations. I really think we're making good progress. Accordingly, during the interim, we had a series of very detailed and lengthy meetings with all of the stakeholders, including the providers, to work on implementation of that redesign and what, if any, statutory tweaks might be necessary as we continue to gear up for full implementation of this reform on July 1st of 2024. That's what Senate File 8 is in front of you. To be very quick, Mr. Chairman, really on page 2 of the bill, you'll see what the meat on the bones is here. In terms of the essential subsidy payments that were contemplated in the first behavioral health redesign bill a couple of sessions ago, this was really a concept to allow the department to be able to offer kind of use the budget, some of the budget, to offer subsidies to your smaller, more rural centers that might not operate at scale. That might not have the type of population base that some of our larger cities and towns do. So the idea was that we would do a calculation of how many behavioral health or mental health providers were in a given radius and subsidize those centers through an additional base payment for operations. Through discussions in the redesign group, especially over this last interim and with the providers, it was really determined that the financial model, the payment model that we're still working on, may not require that we may be able to do this in a more simple fashion. So it was agreed upon that one statutory change might be tweaking that from a shall to a may. That it's not required for us to offer those essential subsidy payments, but that we may with department authority. And then you'll see on the bottom of page 2, I believe lines 16 through 20, that there's, again, that essential subsidy payment as originally contemplated was taking a geographic calculation into consideration of what kind of the provider density in that area would be. And this would make that a bit more simple to say the amount of any essential subsidy payment shall be subject to available funding and based on the service needs as demonstrated by the behavioral health center. So again, I think the group of multiple departments and the provider group and association was comfortable with this bill. That's really it, Mr. Chairman, and once again would reiterate my gratitude to everybody who's involved in this effort, and my gratitude to the Community Mental Health and Substance Abuse Centers for their ongoing partnership and participation with us. I really think we're making good progress. With that, Mr. Chairman, happy to stand for any questions.
Thank you much, Director. And that is a lengthy, involved process, and everyone's involved, and they're not done yet. So a lot of work ahead. Thank you. Questions for the Director Committee? Senator Barlow.
Thank you, Mr. Chairman. I do appreciate the long labors that many have put into this. I guess I look at this shall to may a little differently. I think there are, we've identified, there's two priorities down below. And one of is need instead of geographic area. And the second is available funding, which there are, so there's two demonstrative things that need to be provided before. But then it's completely, even if those are two both positive, it's completely discretionary to the department. And I actually don't like that shall to may. I would rather it be shall if there's a demonstrated need, because you may be the director now, but this is statute that lasts 10 or 15 or 100 years, we hope. And so I guess I'm going to actually bring, and you can make comment to it, Mr. Chairman, but I'm actually going to bring amendment to strike new language and reinsert shall and stick with the approach that if there's and the new approach, if there's a demonstrated need and their funds are available, then we actually support the services. So that's just any feedback on that, Mr. Chairman, would be appreciated.
Yeah, that was the question. Feedback. Go ahead, sir.
Mr. Chairman, Senator Barlow, if I may, I totally understand that perspective and wouldn't disagree with it. For what it's worth, and it might be helpful, and this is not final because we have a little more than a year, 18 months or so before full implementation. But as Chairman Baldwin knows, kind of serving on that group, there's three components to the payment model that we are in process of implementing. One is a base payment, which is similar in concept here. It's not as specific to an essential subsidy payment for a rural or more rural type center, but it is similar in its operation that we will continue to use base payments in this financial model that do not require service provision or volume or that kind of demonstration of outcomes or reporting or what have you. It's just a base payment. Then we'll have kind of a fee-for-service component, similar to a fee-for-service type system to reimburse for those services. And then, as you all know, an outcomes-based payment system that we're, again, still working on the details of how that will be operationalized. But again, Senator Barlow, certainly don't disagree. Obviously, this was the original contemplation here, and we're ready to implement or will be ready to implement what the legislature's pleasure is. I think we're on the same page, but maybe different parts of the page. Thank you.
Further questions, committee? Senator Hutchings.
Thank you, Mr. Chairman. Mr. Johansson, if you could remind me, we're subsidizing this program. Where's the subsidy coming from and how much, how long? Thank you.
Mr. Chairman, Senator Hutchings. So this redesign, this reform really targets basically one area of the department, and I'll say one area, but it's a very large area, and that's our community mental health and substance abuse centers, what's now referred to in this statute as behavioral health centers. Senator Hutchings, that currently is about, in round numbers, about $100 million line item in my budget between 4 units for various outpatient and residential type services. These are funds that we contract out to community mental health centers for the provision of those services. So all of this would be subsumed into that budget, and the 3 areas I mentioned with base payments, whether that includes an essential subsidy payment or not, base payments, payment for service, and then outcomes-based payments would all be kind of contained in that area, and then certainly subject to change up or down in the years to come if the legislature decides to do that.
Gotcha. Follow up? Thank you, Mr. Chairman. You mentioned a fee for service. What exactly is going on there?
Mr. Chairman, Senator Hutchings, so that is essentially, that's a reimbursement for the service that's delivered. So we're kind of taking a 3-pronged approach to the financial model. The fee for service aspect being a center or a provider delivers an hour of therapy or a 15-minute unit of medication management, whatever that might be, we reimburse for that service. So similar to a health insurance plan. And then we add the other components of the payment model that kind of layer onto that with base payments and outcomes incentives.
Thank you.
Further questions, committee? Seeing none. Thank you very much, Director. Comments from the audience? Welcome, Ms. Somerville.
Good morning, Mr. Chairman. Thank you. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. Here I thought this was going to be pretty easy this morning, but I'll share some additional information with the committee in terms of the conversations that we've had during the behavioral health reform process. Specific to, just to set the stage, when this was first contemplated in 2020, the landscape of community mental health was completely different. My directors like to tease me that when I started my job, I had 18 directors and 18 centers on our board. Currently, there are 10. There has been a massive shift in the landscape due to a number of factors. Certainly, just general healthcare administration has become one of those. So we've seen a number of mergers that have maybe complicated what was intended to be a fair subsidy program to help those smaller centers in more rural counties make sure they kept their doors open. A number of those counties now are served by larger entities within the state. And so I just want to share the conversations that we had over the last summer as we worked with the Department of Health and trying to figure out what this subsidy payment program would look like and how to go about that. The first point I think is really important is there is a set amount of funds for the entire community mental health budget. There's no additional dollars that are coming in for this subsidy program. There's no set aside. So any money we take out of the main pot to set aside for the subsidy, it almost becomes a robbing Peter to pay Paul scenario as we worked through the math. You know, if we take 2 million and set it off aside or whatever the number was, that became difficult. The other factor is in working the formula that was, again, intended, I think very well intentioned in the original bill to talk about that. You see that strikeout on page 2, line 16, where it says the subsidy payment shall be based upon the total population of geographic area served by the behavioral health center or other provider. There was discussion about a 35-mile radius. And I cannot tell this committee how many hours I know myself and both Department of Health spent poring over that, trying to figure out how to make that work in a fair way that would support the centers we believe that this piece of statute was intended to support. Again, that got incredibly complicated, and it became very clear last summer that especially that piece of the bill was unworkable. There was no way to go about that. We sorted providers by types within a 35-mile radius. We looked at scenarios including regional services because that is the landscape. A lot of these services are provided on a regional basis now, such as crisis stabilization and residential services. And so as we were going through all of this and discussing with the Department of Health, the pilot project that we are hoping to do over the next year, starting in July of this year, the discussion was certainly, well, we could ask for this statutory change and give the Department of Health some flexibility, or we could, if the recommendation unanimously from all of my centers was to essentially, put $1 in that subsidy program for the pilot year, because there are so many other factors that we are still working out in terms of the payments. The base payment has changed, as was described by the director. The fee-for-service piece is going to change, and most importantly, the outcomes payments. That's certainly a new area that the community mental health centers have never worked in before, and so we felt like we needed some time and some flexibility. So, Mr. Chairman, I know that was a lot of information, but I will stand for questions.
Questions, committee? Senator Barlow.
Thank you, Mr. Chairman. So I guess I'll pose the same question. Is the shall to may problematic? Is that too discretionary for the department, or is that, based on what I just heard in the testimony, you actually do want this to be available? So give me your feedback on the shall to may, caveating that there are two conditions below, meaning need and funds available. Thank you, Mr. Chairman.
Ms. Somerville.
Mr. Chairman, Senator Barlow, I will just say, first of all, this was a unanimous decision by the community mental health centers to support this change. In light of the conversations that we had, I think your point is well taken. We still have a few, and I do mean just a few, what I would deem small independent centers within the state. It is very possible that we will need this And I also think your earlier point is well taken, that we don't know who necessarily will be sitting in the director's chair 5 or 10 years from now, and what that relationship will look like. It's probably risky to change it to a May, but at this point in time, with the relationships we have and where we're going, the directors felt comfortable with it.
Thank you. Further questions? Seeing none. Thank you
you.
very much. Anyone else in the audience wish to comment? A lot of blank stares. Nobody online, I don't believe, for this bill. Okay, let's go ahead. Committee, what's your pleasure on the bill? Do pass, moved by Senator Barlow. Discussion on the bill. Amendments, comments? Seeing none. We'll go ahead and do roll. We're gonna leave the roll open. Senator Dockstader is out. He's heard the testimony, but he'll be back, but we will leave it. So let's go ahead and take roll of what we have.
Thank you, Mr. Chairman. Senator Barlow on, let's see, Senate File 8.
Aye.
Senator Bouchard,
Aye.
Senator Hutchings. No. Chairman Baldwin.
Aye.
As of now, 3 ayes and 1 no.
And we'll get Senator Dockstader's vote when he returns.
Thank you.
Thank you very much. Thank you, committee. We move on to the next bill, Senate File 79. I organize myself here. Go ahead, Senator Barlow.
Mr. Chairman, just for the members of the audience, I have another bill up in another committee in about 10, 15 minutes, so I will be departing, but I've left a proxy vote on the remaining bills, so thank you.
And we appreciate that. We'll still have a quorum, so we're good. This is Senate File 79, Plan of Safe Care Newborns. This is a bill that I sponsored, so I will just present that from here, if that's okay with everyone, because I don't like those chairs. And I can't ask myself questions from this. What this bill is, senators and those listening in, this is an idea conceptualized from some of the discussions that we had last year. And if you remember, we had some discussions about ways of protecting our newborns that are born into a home or a situation where there's some addiction or some drug misuse in the home. That's stuff that we discovered last year and we contemplated, did not make the entire trip through the legislature. This brings that concept back as a way to protect the newborns as well as protecting the families. And that's the concept that this bill introduces and contemplates. Now, I will tell you up front that certainly there are probably some tweaks and some adjustments need made in this bill. And I had the bill drafted with that in mind. Essentially what this does is develop something called the Plan of Safe Care for the infants, and something to help out the parents or the mother of that infant as well, requiring hospitals and healthcare providers to set up this plan, to do some rulemaking through the department who will speak to us today, and to make for effective dates, but effectively setting up a plan of care, putting something in place to assist these infants, assist these families with moving forward, and hopefully protecting those infants as they go forward and have a safer future and have a childhood that's safe from the effects of the drug abuse, as it were. So we can walk through the bill real quick. It's a short bill. It's not a long bill. On page 2, we talk about what the early intervention and education program means. A lot of this is subject to rulemaking if this bill does succeed and pass through the entire system, which is a difficult process, as we all know. I do have an amendment that we'll talk about on page 2. But essentially, this sets up a care team or a team that when that infant is born and this need is identified, to set up a plan of safe care. And so on page 2, it just talks about what a plan of safe care is. And it's just a plan to ensure the safety and well-being of an infant with prenatal substance abuse or prenatal substance use exposure. And you'll note that deeper in the bill, it talks about what that exposure is. Is this exposure from something that was prescribed by the healthcare provider, or something that was given to the mother during the delivery, or what exactly that was? And it differentiates that from abuse. And that's an important concept. On line 21, it talks about when an infant is born with and identified as being affected by substance abuse or withdrawal symptoms resulting from that prenatal drug or alcohol exposure. A member of a patient care team shall develop a plan of safe care in cooperation with the infant's parents or guardians. And then it goes forward and talks about the purpose of that. The purpose mostly being to address the health and substance use treatment needs of the infant and the affected family members. If you remember some of the discussion last year where we talked about, that was specific, a penalty type thing that we talked about what are we going to do with these mothers that come in, and how are we going to penalize them? And that was part of the discussion, and part of the reason that that bill didn't move forward is there was too much emphasis, or it was perceived that there was too much emphasis on the penalties, fines, what have you, to the mothers and to those who came in, thinking that may be a deterrent to actually getting care for the infant. This bill aims to take that away, maybe add it back in somewhere, that's another matter. But this bill aims to treat the infant and the affected family members so that we do provide care and do provide some plans for that affected family or caregiver. And finally, this bill just talks about the things that we take into account. At the bottom of the page 3 there, I talked about the infant's prenatal drug exposure occurred as a result of medication assisted treatment or medication prescribed for the mother by a healthcare provider. And then also whether the mother will be actively engaged in ongoing substance or disorder treatment. That's an important part of this bill as well. And there further we go on to say, if applicable, a copy of the plan of safe care shall be provided to the appropriate community partners, who we'll hear some today from. And then at each year, and actually some of this is already in statute, the patient care team shall report the total number of infants and families for whom a plan of safe care has been developed to the Department of Family Services pursuant to the Comprehensive Addiction and Recovery Act of 2016. And there again, it talks about a safety concern. If a safety concern, those statutes are already in place, and it talks about what we will do if that safety concern is identified. And then finally, on the final page, on page 5, the Department of Family Services, in consultation with the Department of Health, shall promulgate rules and regulations necessary to implement this act. It's expected that there will need be some rules, there will need be some changes and some language identified, and that is expected. And there again, both those departments can speak to us today concerning those needs. Questions from the committee before we hear from the agency? Senator Barlow.
Thank you, Mr. Chairman. So, and maybe this gets taken care of rules, but who convenes the patient care team? That's my first question. And then second, there has to be a presumption of risk of safety concern, because if there actually is a safety concern, that's reportable. And so I think this is meant to be a preemptive step before something is actually reported. And so maybe those two questions: who convenes it, or what do you anticipate, how do you anticipate being convened? Because this does not speak to that. And maybe it's going to be dealt with through rules. And the second part is the presumption of risk to safety. Seems like a delicate line as a mandatory reporter, and you are one, and I am one actually, even as a veterinarian. So it seems like a delicate line between there might be a risk and we should do something, and no, absolutely there is a risk and we have to do something. So thank you, Mr. Chairman.
Thank you, Senator Barlow. The first part of that question is who actually convenes this, who starts? And I was just looking for exactly where, I think on page 2, where it talks about when an infant is born and identified as being affected by substance abuse. And it says a member of a patient care team. I anticipate in the rules making that will be more delineated. My anticipation is that the healthcare provider, be that a doctor, be it a nurse practitioner, be whatever, will be the one that heads that team. But I believe that would be making rulemaking would more further delineate that out. But that's my anticipation. Secondly, that's a very sensitive area in a child with safety concerns, as you well know. And I know in my own personal practice, I err on the side of caution. I think most practitioners do, because the hazard of not reporting something is much greater to the child and to the provider than not presenting that and not laying that out with the appropriate department. So I don't think that reporting changes in my mind. I think that that's part of, if the need is identified that this child is at risk, that would be reported simultaneously with the plan of care, is my anticipation.
Thank you.
Senator Hutchins.
Thank you, Mr. Chair. I guess you kind of anticipated I was going to ask a question, and you kind of answered it when, on page 2, you answered Senator Barlow's question, line 21, when an infant is born and is identified with symptoms. Some questions from some people that were concerned about the bill at the beginning were who was gonna do the testing, when were you gonna do the testing on children in the womb? Could that possibly be done? And I guess one of the fears were we gonna kind of demand this of every woman go through some kind of testing? But you did answer it with this is just gonna be when they're born. Did you have any thoughts about before the child was born?
Thank you, Senator Hutchins. Those are very good questions, actually. My anticipation is, and that doesn't change a lot of what practice is right now, and I hadn't anticipated prenatal. That's probably another subject matter altogether. But my anticipation is when an infant is born, and I will just use the emergency rooms, that's more my experience is at rather than the delivery room. When an infant is brought in with specific signs and symptoms, difficulty breathing, labored breathing, et cetera. I mean, there's a whole list of symptoms. That would be among some of the tests that we do to that infant. Is there a narcotic problem? Is there something there? And we wouldn't, in my mind, everybody wouldn't be tested. We wouldn't be testing every child. But if there's a reason to test that child, if there's a reason to suspect something, that would be, I don't think a lot changes in current practice. All it changes is instead of just sending that patient home, treating a child for 2 or 3 days and sending them home, is that we develop this plan of care, and that's my anticipation.
Thank you, Mr. Chairman.
Further questions, committee? Seeing none. Departments. Welcome to Labor and Health in the hot seat.
Thank you, Lori
Thank you
Hart.
for braving the snow.
Absolutely. Lori Hart, Wyoming State Board of Nursing. And I will tell you, as a women's healthcare nurse practitioner and as a psychiatric nurse practitioner, this speaks to my heart. So thank you, Chairman Baldwin. There is some language in here, though, that I wanted to point out that may be in conflict with our current statutes, specifically talking on page 2, lines 11 and 12, including one or more licensed physicians. Per our current Nurse Practice Act 3321-120, advanced practice nurse practitioners have full independent practice authority. The downside to this language is, as Senator Barlow pointed out, you're writing statute for the future, not for today. And so as we're dealing with a shortage of maternal care within our state, I think it's important to keep all avenues open. If this were passed as it's currently written, I wonder if it would impede the ability of birth centers to be able to practice, or whether they would have to have a physician. Many birth centers are run by certified nurse midwives and staffed by other advanced practice nurses. So just a thought as I was reading through this. Thank you.
And I would recognize that that's something we've discussed, and actually I've discussed with several people, is that it may not be in the OB in the hospital in the delivery room. It may be at home. It may be an infant that's presented to in somebody's office or in an emergency room. There's a lot of cases where it may not be a licensed physician. So that has been discussed, and that will be an anticipated questions. Senator Dockstader.
Yeah, thank you for taking the time. These birth centers, what would you say the percentages are in relation to hospitals? I mean, what are we seeing in birth, the numbers there?
Ms. Hart.
Yes, Chairman Baldwin and Senator Dockstader, I cannot tell you percentage. As we're looking across the country, it's a very small percentage. But what we are seeing is for communities where hospitals have needed to close, birth centers have sometimes filled this gap. So.
Further questions, committee? Senator Barlow.
Thank you, Mr. Chairman. So I think this was identified by one of your colleagues out in the field from my community, this limitation to licensed physicians in this particular line. So striking that, do you think it actually should include team of health care providers and allied health providers? I mean, I don't know how you get to nurses, other things, because maybe it's inclusive of, maybe healthcare providers is the entirety of that. Mr. Chairman, any comment on that?
Ms. Hart?
Chairman Baldwin and Senator Barlow, thank you. That is a really important question. I think Chairman Baldwin's concept in this, that there needs to be a licensed provider who's leading a team, or at least a component of that team, is important. So I do think that perhaps as it's referred to later as a licensed provider would meet that need. That's been defined in statute other places fairly broadly.
And I would suggest it says licensed healthcare provider rather than just licensed provider, because we probably don't want a cosmetologist, but.
Or a veterinarian, perhaps.
Or a veterinarian.
I don't know.
I don't know. I know some darn good veterinarians. Further questions for Ms. Hart, committee? Seeing none. Thank you very much for coming in. Further comments? Other agencies who wish to comment? Seeing none. Anyone else in the room, come on up. This is a very shy audience today. Oh, they're migrating. There's lots of chairs up here. Josh, I think you should come up and sit too. There's 4 chairs, let's fill them. Ms. Davis, it looks like you were the first one to be brave. Go ahead and introduce yourself.
Good morning, Chairman Baldwin, members of the committee. My name is Jen Davis. I work in the governor's office as the Health and Human Services Policy Advisor. And I wanted to just share a little bit of information with you all about this bill today. I won't get into all of the specific details of Plan of Safe Care, and those I'll save that for our great agencies here to explain. But I just wanted to give a little bit of information from the governor's office and our perspective. As a pro-life governor, it is important for the governor that we provide the best opportunities to new mothers and their infants who are suffering from addiction. As we all have heard, the country has seen a growing trend in substance use, and addiction is a disease that needs proper care and support to ensure recovery. When addiction afflicts our new mothers, it's imperative that we have a means to ensure a referral for services during this very vulnerable time. Anyone who has been a new parent knows that there's a lot of additional stresses that come with taking home a new baby. And so by addressing this at the hospital prior to discharge, it's one way that we can help alleviate some of those stresses on a new mom going home with their baby. So this bill ensures that our providers recognize the importance of supporting both moms and babies through the development of a plan of safe care. Not only does this bill ensure that a conversation occurs at the hospital and that referrals are made to support the mother through her recovery, it also ensures that these vulnerable newborns are monitored after discharge for any developmental changes. This is a very vulnerable time in an infant's neurological development. We know that first year of life is critical. And so by having a referral that is in the bill to a local child development center, it ensures that that infant has monitoring and making sure that development is considered over time, not just in that first referral, but we know that we can see changes from exposure into early elementary years. So it's important that we keep a close eye on these infants through their development. The importance of this bill is to ensure that we address the issue of addiction and proper care for the mother and infant prior to that discharge. Once mothers leave the hospital, we often find it more difficult to connect to resources as life just gets busy when you take a newborn home. And so we have our best opportunity to do this support prior to discharge. Also, this bill ensures that if there are additional safety concerns, that the provider will notify DFS. As was mentioned earlier about our providers are mandated reporters, but every person in this room and watching online, every citizen of Wyoming is a mandated reporter. So that does not change anything with this bill. We all have an obligation to report if we have a safety concern for an infant or any child. Also, the goal is to keep families safe and to help them prosper, but also to ensure the safety of the infant is the priority. The Department of Family Services values keeping families safe and together whenever possible. That's evident through their new program, the Wyoming Home Matters, that focuses on this. And this bill allows for that support while ensuring that the agency can intervene if necessary. Additionally, I just wanted to point out that this also aligns with the work that you all did last year in the ARPA CapCon to make priority for substance abuse, particularly our mothers and newborns, by increasing bed capacity in the state. This now has a good alignment with this bill to ensure that we have additional beds to support that as these women and infants are identified. And I will save conversation for the agencies and for the providers here to talk about how infants are currently being identified for screening. I'll let the experts speak to that. But just wanted to say that our office stands in support of this bill as Wyoming works to ensure that women and infant health is a top priority. So thank you, and I'm happy to stand for any questions.
Thank you, Ms. Davis. Questions from Ms. Davis Committee? Seeing none, thank you very much.
Thank you.
Can arm wrestle over who's next.
Good morning, Chairman, members of the committee. My name is Lindsay Schilling, and I'm the Division Administrator for Social Services at DFS. And I prepared just a few brief comments on this bill this morning. To start, we're very thankful for the work that's gone into drafting this bill. We believe it goes a long way in supporting work already underway by the statewide task force. We're very grateful for the intentional focus on the impacts of substance use and exposure on newborns and creating supports for both the mom and the baby. This effort is in direct support of agency goals to keep families intact and to keep babies at home when it's safe to do so. Just to speak a little bit to prior questions, we don't have any proposed amendments or language changes. Our general consensus has been that any areas where clarification would be helpful, those can be resolved through rule and policy. And then just a few metrics and data pieces from DFS. In calendar year 2022, we received reports of 132 infants with prenatal substance exposure. 122 were positive at birth. 10 of those were prenatal only. 130 impacted families, and we currently have 33 of those babies in agency custody. So any focus on providing supports to moms and babies prior to protective custody or the need to separate families is a very good thing in our opinion. Thank you.
Thank you, Ms. Schilling. Questions for Ms. Schilling? Senator Hutchings. Go ahead, Ms.
Chairman,
Schilling.
Senator Hutchings, of
Thank you.
course. So this is calendar year 2022. We received reports of 132 infants with prenatal substance exposure. 122 of those were positive at birth. 10 of those reports were prenatal testing only. It was 130 families, and we currently have 33 of those infants in protective custody, which is 31%, so a third of the reports that we received.
Can I get you, Ms. Schilling, can I get you to email us those statistics perhaps? Because I don't write as fast as Senator Hutchings. Thank you very much.
Chairman,
Further
absolutely.
questions, committee? No further questions? Okay, they arm wrestled and you win, ma'am. You're next.
Thank you, Chairman Baldwin and committee. I'm Angie Van Houten with the Wyoming Department of Health, Community Health Section Chief. We've been working closely with the Department of Family Services through the plans of safe care discussions that have been being had over the last several years, and we have no concerns with the bill as written. And just stand for any questions, if there are any.
Yeah, I'll say it again with the green light. Any questions, committee? Seeing none, thank you very much. Before we go to Josh, I'm not putting you off, Josh. There was mention, I believe, about a task force. Can you identify what that task force is? I know half the room is on the task force, but if you could identify what the task force is or what it's called. If not, Ms. Davis can probably tell us because she may know about it.
Chairman, members of the committee, certainly. In 2021, Wyoming was accepted into an in-depth technical assistance program through the National Center for Substance Use and Child Welfare. The purpose of the technical assistance was to allow for a multidisciplinary approach to development and implementation of plans of safe care. So there is a statewide multidisciplinary task force that includes the Department of Health, several divisions within the Department of Health, DFS, the Governor's Office, Wyoming Early Childhood Head Start, the Perinatal Quality Control Collaborative, the Wyoming Hospital Association, the Wyoming Children's Justice Project, the Wyoming Children's Trust Fund, Parents as Teachers. We have voices and representatives from adults and adolescents with lived experience, Representative Provenza and Senator Nethercott. So those are all people that have come together to focus on really designing the best implementation of plans of safe care across Wyoming.
Senator Knox, a question.
How often does this group come together? It's a big Zoom meeting? It's a meeting here in Cheyenne? What is this? First I've heard of it.
Go ahead, Ms. Davis.
Chairman Baldwin, Senator Dockstetter. The group has been meeting, as Ms. Schilling mentioned, over a year. The meetings right now are kind of on a quarterly as needed basis with the TA Center. They have stood up a pilot for this in 2 of our counties, Albany County and Laramie County. And so as that is evolving, that has not been meeting quite as frequently, but initially I believe it was meeting monthly and then into quarterly.
We say thank goodness for Zoom. Okay, any further questions? We'll move on to the Wyoming Hospital Association. Welcome, Josh.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. As you heard, we have been participating in the steering committee and the task force group, and we're in support of this bill. All of our members have been frankly enthusiastic about this concept and moving it forward. As Ms. Davis mentioned, we have 2 hospitals that have volunteered to participate in the pilot. And we have some experts and providers here in the room that I'm sure would be happy to tell you about current practice and how this improves their work with these mothers and babies going forward. I'm certainly not in a position to say how that day-to-day work goes, but I am here to say that the association is happy to support this. And if there's a role for us moving forward in implementation after the rule process, if we can be of assistance to make sure that the framework is such that it can go into any of our birthing hospitals and be successful, we're happy to be supportive in any way we can. And I would stand for questions.
Questions for Josh? Senator Dockstetter?
The whole group.
For the whole group, I'll be where.
It's okay now?
Go ahead.
So it's Family Services and Department of Health. They're going to promulgate the rules. Got a wish list in that promulgation of rules. Which any of you would like to address what that list might be? What you would like to see done as a group?
This is like sitting on Santa Claus's lap here. A wish list. Go ahead, Ms. Schilling.
Chairman, Senator Dockstetter, I always look forward to the opportunity to collaborate with stakeholders and partners in drafting rule and policy. I think it's the most valuable piece of that whole process. From a DFS perspective, I would intend to recommend incorporation of our Why Home Matters and a focus on primary prevention at every opportunity that there would be throughout that process.
Further thoughts? Santa Claus has never been so happy. Okay. Any further questions for the group? Seeing none, thank you very much. Further testimony from the audience. Again, don't be shy. There's 4 chairs. And they're all warm, as a matter of fact. Welcome back, Ms. Somerville.
Thank you, Mr. Chairman. Andy Somerville, Executive Director with WAMSAC, and I just have a few brief comments and maybe give a little grief to my colleagues up here. WAMSAC is also participating in the Plans of Safe Care Task Force as the provider on the back end. So we provide a significant portion of the state's both residential substance use disorder services and outpatient services throughout the state. And so we've been working with them just to make sure that we've got that entire continuum of care, so that as the hospitals develop a plan of safe care, they know where their options are and how they can move them around. I've spoken with some colleagues in other states that have developed these plans. They've seen them be successful in terms of all of the goals that you've heard in previous testimony, trying to keep families together, getting folks into and mothers and children into services that are needed, and doing that early in the process. I'd just also like to mention for this committee, one of the things that Wyoming is fortunate to have is not many, but we have some beds for what we call as parenting women. So if a hospital identifies an infant that's been exposed and maybe a substance use issue, and the appropriate course of action after assessment is for residential treatment, we actually have beds in Wyoming where that mother can bring the infant with her to treatment. And that's a really important piece of that puzzle as we're trying to help the mother get better, making sure that the child has proper care, and then our teams work really hard to work with them on all of the other pieces: housing, jobs, daycare, so that when they leave our facilities, they're in the best shape that we can possibly put them in. So we stand in full support of the bill, Mr. Chairman, and I'd be happy to answer any questions.
Questions, Ms. Somerville, committee?
Thank
Seeing
you.
none, thank you very much for your testimony. Further testimony? Go ahead and push for the green light and introduce yourself and tell us all about what you got in your mind.
Chairman Baldwin, hi. I'm Dr. Renee Hinkle. I'm an OBGYN in Cheyenne. I've been here 24 years and worked at Cheyenne Regional Medical Center all of that time. I'm here as an OBGYN just to talk about some of the prenatal implications of this bill. I stand in support of the bill. Erin is our nurse manager at the hospital. She has been working on the task force that has been implementing this in Laramie, or trying to implement this in Laramie County. And they have been meeting, I think, every couple of weeks for the last year. So it has been a pretty intensive group that they're meeting with. This is super important. I'm very excited to see a bill like this year because these women really should not be treated as criminals, but need the help for the medical problem that they have of addiction. So I think this is amazing. Just to get down to some of the details that you guys had asked earlier, there are many ways that women are identified as being addicted to substances, and many ways that we show that they are taking substances during pregnancy. As of currently, we have not had a place to send them while they're pregnant. We can try and get them help for their addiction. We can, discuss that with them. We can monitor them. We can, if they're opioids, we can try and help them get off opioids and onto some other medications. But we haven't had a place that could address all of those issues all at once, and this does supply that. So it's a really nice thing for all the people taking care of, and I agree with the providers. Healthcare providers is a great way to say that, because we do have a lot of routine healthcare providers, not just physicians, taking care of pregnant women in this state. So a place for us to send those women and get them in the system before they deliver, that would be ideal. Many times, even if we identify them as having done substances during pregnancy, we cannot make a formal referral to any agency until, currently anyway, until they deliver. And then we identify them, test them in labor, and then they test the baby once the baby is delivered. So having a system in place for prenatal referrals and getting them into the system prior to delivery would be ideal both for the patient and the baby. Aaron will talk a little bit more about the statistics on how much this helps moms and babies to keep from having to be separated and go into custody if we can treat them early. So now when we find somebody, it does trigger some processes, and there is a policy at the hospital where there are several different things that trigger us to test the mom, whether it's late prenatal care, prior abuse in the past, abuse during the pregnancy. There's a whole list of things that make us test the mom. And if the mom tests positive, then we test the baby. Thank you.
Very good. Question specifically for the doctor. Senator Bouchard.
Thank you, Mr. Chairman. We've had other bills that we've had in the committee, and I've had real concerns when we try to criminalize. So I want to have more of that balance in there, because I'm really concerned that when we do separate babies and mothers, and we create a bigger problem. And so how do we get that balance in this? Because you've got DFS on one side, depending on who was elected as a district attorney, that may be involved in the loop. How do we slow the law enforcement side down to let the care come in? I mean, that's where I want to find balance in this, to make sure we put it there now.
Okay,
Doctor,
thank you.
go ahead.
Chairman Baldwin, Senator Bouchard. Erin has, because she's been working on the task force, they have a whole plan for that. So if you're okay with it, I'll go ahead and let Erin answer that question.
Erin, go ahead and introduce yourself and answer the question and tell us anything else you got in your mind.
Good morning. So I'm Erin McKinney. I'm the Director for Women and Children's Services, have worked alongside Dr. Hinkle I've been there 22 years. And so to answer your questions, with the task force, there is a specific education component of a committee for that. And that includes, one of the big parts of that is implicit bias, and understanding where our own biases come into play with moms that are using substances. And so it is a big joint effort with public health and DFS. And I think one of the great things is that both public health and DFS are in this together. So it's not one separate way. And so it'll be a lot of education, part of that task force with those that touch these patients.
Further questions, committee? Okay, thank you very much. That leaves one person in a hot seat. Go ahead and introduce.
Can I?
Oh, go ahead. I'm sorry. Erin, go ahead.
Thank you. So I'm actually really excited to be here. You're all familiar faces. I was here last year when the bills were up about criminalizing women, and to have a shift to really talk about the plans of safe care, and actually the federal government put into place in 2016 that hospitals do put in plans of safe care for our moms and our babies. So this is really exciting, and I think as you representing our state, it's to be proud of the work that is happening within the state. We've already talked about what the criminalizing of women. It's not best practice. In fact, women will not go to have prenatal care. They are more likely to come in, have a baby, and possibly leave their baby. Because of the judgment, maybe they've already had children in protective custody and they think this is going to happen again. And so identifying the women ahead of time with our screenings in place, and sometimes moms will self-report that they're using, and we would love, as the culture changes, to where moms feel comfortable knowing that there's something in the plans essentially for them when they come to the hospital and when they're discharged. And so I think about it as we wrap our moms and babies around services, and as we bundle our babies is what I think about. It's really bundling our moms and our babies together with this. And so been a part of the task force with plans of safe care a year and a half or so, the different committees that we have, really working for our moms and babies, advocating for them. And I think it's great to see something that comes up about not criminalizing our women.
Questions for Senator Bouchard?
Thank you, Mr. Chairman. I've seen a lot of man on the street videos with the fentanyl, and and young women that are asked, you know, what would you do different? And they tell people right out, don't come here on the street, don't do this, don't get on drugs, even though they can't get off of drugs themselves. So what are we seeing? What are the numbers on fentanyl now that we're seeing? Are we seeing anything here in Wyoming? Like, I mean, in other states, it's like walking zombies on the streets.
Yes.
What are we seeing here for numbers now, and especially with young women?
Sure. Thank
Erin,
you,
go
Senator
ahead.
Bouchard. Thank you. While I don't have the specific numbers on fentanyl, this is relatively new for the moms that we are seeing who are using the substances. It's way more accessible, and it's out there. And sometimes they don't know that that is what they're taking. So what we've primarily seen is methamphetamine. And now shifting to, seeing, and we've had, within the last 6 months, there's been recent cases of moms that are using fentanyl and helping them. And it, as Dr. Hinkle talked about, when we're able to get our moms into services, there's medication assistant therapy at MAT therapy. We have physicians that are licensed. You have to be specific licensed to be able to prescribe that therapy for our moms. And so if we're able ahead of time, like I said, and so hopefully, and then at the time when they're delivered, to advocate and say, these are the services that are available for you.
And I would throw in there, perhaps Dr. Hinkle knows this too, the DEA did change the prescribing of the the opioid treatments. They did change some of that licensing requirement. So that's changing as we speak.
Chairman Baldwin, yes, it has been changing, and I'm sure you know because this body helped pass it, but there is teaching requirements, education requirements for all providers now on opioid prescription. So the fentanyl, to answer Senator Bouchard's questions a little bit more, the fentanyl is a little bit more difficult because it is an opioid and it is a little bit more difficult to identify the signs. Methamphetamine is a little bit easier to see. And so, we will be learning more about that as that becomes a little bit more popular, for lack of a better word, here in Wyoming. But we would catch that on our routine screen because opioids are part of our routine screen. And so we would see that it's opioids, and I'm sure that fentanyl will become a breakout of that at some point.
And it's just a piece of public information, is that we're working with the Department of Pharmacy to do more education for legislators in particular about fentanyl. I've never talked about fentanyl more than I have in the last month.
Yeah.
In the last week, for that matter. Senator Bouchard, go ahead. You have follow-up, sir.
Thank you, Mr. Chairman. Yeah, I mean, I guess more of a statement, but maybe you can elaborate. What I've seen is the women, especially women, because they are the ones that are interviewed the most. They may say, hey, I was looking for a heroin fix, and the dealers are mixing fentanyl and other drugs. They don't really even know what they're taking. That's a big concern out there because they really don't. I mean, it's and they're so hooked they can't get off. And I'm like I said, I've seen the testimony where they're telling people, don't come here, don't get on the street. One young woman was asked if she knew her, or if a family member that she could call or anything, and she said, I just don't want them to see me like this. So they're very aware, and they just, so I mean, that's why I'm really concerned. We have to make sure we don't criminalize, because we'll never get them off the street if we don't. And the problems that are that once they become pregnant, I mean, some of the women are actually paying for the drugs by performing things, and that's, I mean, it's just a vicious circle. So.
Okay, comments? Okay, anything else, Erin? I'm not going to cut you off this time. I apologize.
Right,
Okay, ma'am, introduce yourself and go ahead.
Okay, it works. Good morning, Chairman, Senators. Thank you. My name is Karen Miller. I'm a certified peer specialist with mastery in forensic endorsements. I'm a person in long-term recovery. What that means is that I've been clean for over 17 years. I work with addicted and recovering individuals in this state. I've been able to kind of like turn my mess into a message, so to speak. All right. The the first time I heard of the plan of safe care was last Tuesday. Okay, so a little over a week ago, and I became very excited about hearing it. The first time I heard about this bill was yesterday, so I'm like, I want in on that. What I wish to convey is that there's not a mom out there who wakes up one day, finds out they're pregnant, and say, "How can I mess this kid up? I want to continue using drugs." A mom who is substance dependent is a scared mom. And so I believe that the gravity of this bill to help foster maybe a sense of destigmatization and a sense of safety in that if they do reach out for help, they may not be criminalized is monumental. Okay. The people I get to work with, I tell them that we're not bad people getting good, we're sick people getting well. Okay. I'm a mother myself. My first two children were born when I was clean. I was clean throughout the entire pregnancy. My twins, I was using drugs when I became pregnant and used for the first 2 months. I did not know I was pregnant. Boy, was I scared when I found out I was pregnant. When I found out I had twins, I was going to have twins, I was petrified. I did not self-report. I was beyond terrified until the moment I gave birth. I gave birth to 2 very healthy girls. They excel at what they do today. All of my children are adults. I didn't raise them all the way due to my behaviors, but I have wonderful, close relationships with them. I support mothers who have had their children in active addiction. I've watched the trauma of having them separated. It's invasive. I think it's counterproductive to have the children taken away at birth. There's been success stories, we've kept them clean. But that bond, man, they got discouraged. They got really discouraged. They were gone for 6, 9 months, a year, jumping through the hoops. Why am I even doing this? Those questions. And all of us in a program trying to come around them. Come on, you can do this. Don't give up. And just a community of grassroots cheerleaders. So in order to have this be a possibility for people, I'm so stoked. So I thank you so much for your time.
Thank you very much for that testimony. I have to tell you, that's one of my favorite parts of this committee, is hearing testimony from the heart. We hear from agency directors and other people all the time, but to hear good testimony from the public, from the heart, that's valuable. And we appreciate you coming today and braving the snow. And I believe Senator Hutchins has something to say. I have a question for you. Go ahead.
Yes, thank you, Mr. Chairman. Karen, thank you. I loved your testimony. I may not agree with all of it, but I loved it. And I think you were brave to come in and give us your story. And I just want to say congratulations. Thank you, Senator.
Further questions, comments, committee? Oh, Senator Dockstader.
First of all, Karen, thank you very much. Back to the doctor, you said, and I wasn't clear, you said we're doing this in Laramie County now, we've got a program put together. Did I understand that right? Then we have other places that just aren't as far along advanced in such a program and preparation? Is the rural areas, are they suffering? Maybe a little more clarification.
Okay.
Dr. Engel, go ahead.
Chairman, Senator Doc Sutter. Thank you. Yeah, so the task force has set up 2 counties to trial this processes of care, processes of safe care. And those 2 counties are Laramie County and Albany County. Once they have set up how the processes will work through the hospitals and the physicians, the providers, as well as through public health and DFS, then we will roll it out to the other counties in the state. So we're just trying to, the counties here are just trying to get the processes going. So yes, this is a problem across the state for sure. And as I said, we have processes that we've been using, they're just not ideal. And so the processes of safe care will help us coordinate those throughout the state.
Further questions, committee? Okay, thank you very much. Anyone else in the audience? Oh, go ahead, Karen. The green light's hard to get on.
It is. I do have one more point to make about the recovery process.
Please, go ahead.
A huge part of the recovery and what keeps us coming back is taking that responsibility, owning up to the fact that there is damage done. And that's where the recovery is sustained. And we can say, it's not like the most successful people in recovery admit, holy cow, I did a bad thing. This was not good. And so that's when, for clarification, we don't want to just be absolved. We want to repair. So, thank you.
Very good. Thank you very much. Others in the audience who wish to testify? I know we've got a couple waiting online. Let's go ahead and admit them both. If anyone else in the audience wishes to testify, come on up, have a seat. Because sometimes getting these folks online lined up takes a minute. I see a face, I can't see a name. Is that April? Okay. Go ahead, ma'am. You're live. Go ahead and unmute and speak to us.
Good morning, Chairman and committee members. I wish I would have braved the snow today, but I'm feeling a fever. So I'm Tara Muir. I am the Public Policies Director with the Wyoming Coalition Against Domestic Violence and Sexual Assault. I'll be brief. We aren't a part of this fabulous task force, but we wish we were. We work on behalf of survivors across the state in our network of programs and shelters, including a civil legal program. Our programs talk to survivors every day, hundreds of them. We do support this Senate File 79. Thank you, Senator Baldwin, for bringing it and all the work of the task force and creating it. It addresses the modern day understanding of addiction as a medical issue and that the treatment must be prioritized. So we're 100% behind that. We haven't heard, I really appreciate the testimony of Karen Miller. We have to hear from people with the lived experience. What I haven't heard a lot of, and it's just a point we want to raise, the mandatory reporting piece. We're all mandatory reporters for child abuse, so I don't know if that needs to be emphasized in the law. What we do know about sexual assault victims in particular is they're much more prone to become addicted because of trying to self-medicate the trauma and the lasting effects of a rape. Guilt, shame, it was my fault and not the rapist's fault. So we have a particular interest in how moms move forward with a pregnancy and how they're treated. So we hope that we have crisis centers and shelters in every county, that those programs are known to any of these response teams and safe planning teams, that there be some referrals. Many of a mom struggling with substance abuse needs to see a light at the end of the tunnel as well if she's under the trauma of previous bad experiences, a sexual assault child sexual abuse is a leading indicator that you will have a substance abuse problem when we look at the adverse childhood experiences work. That's so good about how do we get in there and do primary prevention, build up resiliency. So a good referral to a crisis center just to start managing kind of a different safety plan for sexual assault survivors. Too often, they've landed in an abusive domestic violence relationship as well. And like it or not, abusers are great at furthering that addiction, making sure that mom looks like an addict, sounds like an addict, develops mental health issues. So as I've been following these topics, it'd be great to hear about co-occurring disorders, that it's not just addiction. There may be some underlying trauma, underlying mental health issues that also need to be addressed. I know our community health centers, community behavioral health centers certainly address that, but it's just some points to bring to light for this committee and to the task force. But we are 100% supportive and thank all of you for the time this morning. Happy to take any questions.
Questions, committee? Just an editorial or a mandatory reporting, and this is an editorial, in my opinion only. IMHO, as you would see online. And that is mandatory reporting is mandatory for everyone. I think it's an educational issue. And while not detailing the details, in my home county, in my hometown, we have an issue of where reporting didn't happen and we had a tragic outcome. And it's a big deal. And I think it's an education piece we need to get out to the public, healthcare providers, everybody. And I think it's an education piece. I think it's in law. I think it's there. I think we don't need to make new laws. We don't need to do that. We just need to get the education out there and get people, pardon the phrase, if you see something, say something. So that was just my own editorial. Take that as you may. Thank you very much for your testimony. We'll go ahead in person one more before we do any more. If there's somebody else online, go ahead and put them in.
Mr. Chairman, we do have somebody else online with their, I'm going to admit April Kranz, Dr. April Kranz.
We'll have April stand by and we'll go ahead here and do the in-person, ma'am. If you want to push and get the green button and identify, and we'll do your testimony and then we'll go online. Go ahead.
Okay. Thank you, Mr. Chairman, members of the committee. My name is Lilia Olejnik. I am a Laramie County resident, and I'm here as a mother. I have a child, and I appreciate a lot of things about the intention of this bill in regards to not separating the mother from the child and not criminalizing the mother because of substance abuse. However, I am concerned about the physician team and how it may impact the ability of a parent or of another family member to have a say in this process. And as a mother, like I said, I would rather have my husband, my mother, or another family member to be part of the process, the decision-making process, not only in the care of myself, but also of the child. And I know that that's not always a possibility, but what if there is? And we see a lot of grandparents these days stepping up to actually raise the children. And sometimes medications don't work. The physician team might not want to admit to that, and it's not, it's, I would imagine as a physician that would be frustrating, but it happens. I know it does. I've been close to that. So that is the concern that I have regarding this bill. And if there are already systems in place that are not ideal, nothing's ever ideal in the first place. But if they're already there, then why don't we improve those to make it better for that process? And also, how do we, like Senator Bashar brought up, how do we stop the law enforcement piece of it? And the other concern I have is what would be defined as substance? I mean, if I'm taking a painkiller, and is that a substance, or is it just who defines that, and what if that changes? And do we really want to have state agencies, government agencies, being the center of decision making for children and families? And it should be the family. Could be the church. I mean, there's so many ways of addressing this issue that it's truly heartbreaking. It really is. And so I just wanted to come down here and express that concern that the state needs to be very careful into not getting into family business. We have systems in place. Let's improve them. And you know, I think that will make our community stronger. Thank you.
Thank you very much for that testimony. As before, you heard me say here before, we appreciate testimony from the heart. That was clearly heartfelt. Are there any questions for Senator Hutchings? Go ahead, ma'am.
Mr. Chairman, this isn't so much a question for Lilia, but it's a comment. If you look at page 3 on the bill, and you probably don't have it in front of you, but I appreciate your concerns, and those were some of the concerns that were brought up to me as well. But at the top of page 3, on lines, let's go 1, 2, 3, it pretty much says the plan of care is going to be done in cooperation with the infant's parent and or guardian. So you see there that the plan has that kind of your concern already there. And then when you talk about reporting and getting law enforcement and DFS into it, nobody wants DFS in their business. We can all say that. But there are times, Lilia, when the abuse, as you'll see somewhere else in the bill, I can't find it because my screen's not working. There's a place in there where it says they're going to identify whether the abuse is on purpose. So there's a portion where we're going to try to take care of you that you're not really meaning to, like you say, you're on a medication and your baby is affected or whatever. So all that's covered, I think, Mr. Chairman. Bottom of page 3. Thank you. I just can't scroll my screen. All right, thank you.
Mr. Chairman,
Go ahead.
Senator
That help?
Hutchins. Yes, that does help. Thank you. And I appreciate you clarifying that. I'm still questioning though, however, why don't we just improve the systems we have in place? Because if they're supposed to be reporting, then report. If it's a training issue, then the leadership needs to do their job and make sure that their people are trained. So anyway, thank you.
Thank you very much for that testimony. Oh, one more question. 2 more questions.
I appreciate that. Thank you for taking the time, Lilia. We have the patient care team identified as physicians. Then we have the follow-up in cooperation with the infant's parents or guardians. Are you seeing an angle in there, Lilia, that might, do we expand to beyond infants' parents? Your thoughts on that? Is there, you know, if they don't, if the family doesn't, it's not, maybe the family's disjointed in some way, do we need a sibling, or what's your thoughts there? I'm trying to track what you're looking for there.
Go ahead.
Mr. Chairman, Senator, yes, I think it will be helpful to have, because let's face it, not everybody gets along in their families or are suitable. So yeah, that I think it would be beneficial to have other family members in the picture available, a sibling, an aunt, you know, what have you.
Thank you. Thank you for coming.
Senator Bouchard.
Thank you, Mr. Chairman. I think I need to just make a little bit of a comment about how things work with like grandparents, for instance. We probably have to go back and fix things there because I don't remember if we did make any changes, but sometimes grandparents are just cut out and we need to probably go into another bill, another piece of legislation to fix some of that. I mean, because sometimes I think there's been cases where a parent has said, no, the grandparents can't be involved, and that's caused a big problem where they should have been involved, and they were blocked because of parental rights. So, and it wasn't in the best interest of the child, of the real victim, which was the child. So these bills, I mean, there isn't a one size fits all, but obviously we have a problem coming down the pike that's gonna get worse with more fentanyl coming into the country. It's just gonna get, become a bigger problem. But I think that we hear what you're saying. I think that we can start looking, maybe in this committee, we can start looking at how we can touch those other parts of the family and bring them in by fixing that grandparents' rights. Because we've seen grandparents, we've had testimony where grandparents were shut out and they wanted to help and they couldn't. And sometimes even cases where custody was given up and the grandparents lost all contact because of that. So anyway.
Okay,
Thank you.
thank you very much. If there's any further testimony, we're gonna kind of hurry it along here. We're gonna try to wrap this one up and get it voted on if we can. Go ahead, sir.
Thank you, Mr. Chairman, members of the committee. My name is Mike Lehman. I represent the Catholic Diocese of Cheyenne. I wasn't intending to testify this morning, but listening to the testimony, I think a lot of great points have been brought up. That we would definitely support the concept. We do think it's important to balance the rights of the family, but also recognizing that a lot of families are facing these challenges, and so to have something upstream is critical. I would just comment on the critical importance of keeping children connected to their biological families where possible. We know, I've done a lot of reading recently about a phenomenon called genealogical bewilderment that children have when they are separated from their biological families. My wife and I adopted a daughter from China, and she's an amazing young woman. But growing up, we heard very often, nobody looks like me. And to experience that, to encounter that, it's something that, adoption's a beautiful, wonderful thing, and it is a wonderful, thing that we've experienced, and she has as well. But there is harm that is done, and so anything that we can do to try to bring people the healing they need, in the case of addiction, and keep families together is something that we would support. Thank you, Mr. Chairman.
Questions for Mr. Lehman? Thank you very much for coming up and testifying. I believe we have another one online. April, is that correct?
Yeah, Dr. April Kranz is
Okay,
online.
and there she is.
Hi.
Introduce yourself and talk to us.
Hi, I'm Dr. April Kranz. I'm an internal medicine and pediatrics physician for the past 14 years, and I'm the chief of pediatric hospital medicine at Cheyenne Regional Medical Center now. I have been taking care of these babies regularly for the past 5 years since I've been at Cheyenne Regional. And I just want to say thank you for hearing this bill. We're all really excited about it, all the doctors and nurses and the care teams at the hospital who care for these babies all the time and have been very frustrated with the lack of resources to give them the best care, give the babies and the moms and the families the best care that they need and that they deserve. So this is a huge improvement on the current situation. I would say to my last neighbor's comments there that I think of this as very much building on the system that we have now. It doesn't feel like a totally new thing to me. It's really, working within the framework that we have had all along. With DFS and it's really, to me, it's really connecting the babies and the moms to the community resources in a much more effective way that we haven't had a way to do before. Because up to now, as a pediatrician, the only options have been one, if this baby is identified as having a drug of abuse present in their urine at the time of birth, then we go down the law enforcement pathway and separate the mom and the baby, which, isn't always a great thing. Sometimes it's necessary, but nobody wants that. And then the alternative is if this drug, for whatever reason, isn't found in the baby's urine at the time of birth, we basically have nothing. And so we're in a situation where it's very difficult to connect this mom and baby with resources. And it's scary for us as the people who care for these families, because we just kind of feel like we're throwing them out to the wolves because there hasn't been a good system in place to, like I say, connect them to the resources and the support they really need. I want to echo some of my colleagues' comments that I'm really hopeful that the plans of safe care will start to enable us to identify these women earlier, because very often, these women are self-reporting early in pregnancy, or they come in with an early pregnancy test, or I'm sorry, an early drug test, demonstrating that yes, they have been using drugs early in pregnancy. And boy, what an amazing opportunity it would be to be able to earn those women's trust early. And to demonstrate to them, hey, we know that you're struggling with a problem, a health problem here, and we can help you, and we want to help you. We want to support you in keeping your baby healthy, and keeping yourself healthy, and getting to where you really want to be. Because the majority of these moms that I've met, they don't like my other, like Karen was saying, they don't want to mess up their babies. There's an incredible feeling of guilt and shame and remorse when this happens, and they they don't want to be that person who harms a newborn. Nobody wants to do that. And so this is, I'm just so excited to have this opportunity to start providing these moms with another option. The fentanyl question, actually interesting from my standpoint. I'm seeing, and my colleagues and I are seeing, the first crop of babies who are being born addicted to fentanyl, even though we were hearing that this was a growing trend in the last 6 to 9 months or so. Well, now we're seeing the babies that are being born addicted to fentanyl. And I got to say, in my career and earlier, I've cared for babies who were born addicted to heroin for sure. And methamphetamine is, definitely that's the majority of the substance exposed newborns we were seeing. And methamphetamine doesn't really have very much of a withdrawal syndrome in newborns, whereas the opioids like heroin and fentanyl really do. And fentanyl is, wow, I've never seen babies require this high doses of morphine as they are requiring to control their withdrawal symptoms. So boy, it is a serious problem, and they have to be in the hospital for a long time just for us to treat the physical symptoms of withdrawal. So amazing opportunity to identify these women early and get them treatment so that we can improve outcomes for everybody involved. I want to also address the question about DFS and partnering with families. As a mandatory reporter, yes, we report to DFS anytime there is an illegal substance for sure that's identified in the baby. But the thing is, DFS doesn't take babies away. And so I think, I'm interacting with DFS workers and law enforcement on a regular basis in the course of this work. And we're all frustrated. They don't want to take babies away. We don't want to take babies away. We want the best outcomes. Everybody wants the same thing here. And primarily DFS, in my experience, they're offering services to these families. They're providing kind of supervision, and this bill is going to allow them and empower them to do more of the good part of their job, not the taking away babies part, or not having the babies in protective custody part of their job, but really the supporting families part of their job, which of the many DFS workers I've spoken with and interacted with, that's why they're there. That's why they sign up to do this. They want to protect families. They want to help families succeed. And I have, in my part of in my part of the puzzle here, I routinely see families, extended families involved. I think for everybody on the care team, that's the preference, because there is that biological connection and that natural desire to care for that baby, and so that's always the first choice as a member of the care team, to have a member of the family be the caregiver for this child. Again, as the physician, I don't get to choose who that caregiver is going to be if they are not able to be in the custody of their mother. I believe that is down to DFS and to the judge who's hearing about the case. But again, I'm excited that this bill is going to allow us to do more for these families outside of the legal system. So thank you very much, and I will stand for questions.
Thank you very much, Dr. Krantz. Questions, committee? Seeing none. Thank you very much for your testimony. I believe that's it online. I believe that's it in the room. Committee, what's your pleasure?
Do pass.
Do pass by Senator Dockstetter. We won't worry about the second. I'll second. Any discussion or amendments, or I believe that Senator Hutchings has an amendment here sitting in front of me on page 2. Page 2, line 12. Striking physicians and changing that to licensed health, or just changing that part to healthcare providers. So the read would read include one or more licensed healthcare providers who provide medical care services to a patient, which I believe would be inclusive of the entire healthcare team. Suggestions, questions?
Mr. Chairman,
Go ahead.
Ensuring that with that wording, we're still keeping licensed healthcare providers. That's physicians. That's who else?
Yeah, that's in statutes. That would be advanced nurse practitioners. That would be PAs, nurse midwives. That pretty much includes the whole gamut of folks who do healthcare.
All right.
Okay, you've heard the motion on the bill, Senator Hutchings' motion. On the motion on page 2, striking physicians and changing that to healthcare providers. All in favor of that amendment, say aye.
Aye.
All opposed, say no. That amendment passes. Any further amendments or changes, committee?
Mr. Chairman, page.
Oh, there's 2 on there, I'm sorry.
Senator Dockstetter.
Go ahead, that's Senator Dockstetter.
Let's clear up the sheet there.
Here, I'm gonna give this back to you because I don't.
Should I continue or let
Yeah,
you
go
go
ahead,
ahead?
go ahead.
Was this part of what you wanted?
Let's
The
see.
prenatal
I'm trying to
on
read the
page
notes
2,
over
line 12, strike, wait, no, on page 2, lines 21, strike the word when and insert prenatally or when. I think it's important to add the prenatal in there somehow, some way. Thank you, Mr. Chairman.
So can you clarify, Senator Hutchings, how would you say it? What would the wording be? Just read that sentence to me.
Prenatally or when an infant is born. There was testimony that we can test prenatally, and I think it's important because if a child is identified earlier than at birth, we can get the process started earlier on the healthcare team, or the plan of patient care team gets started on their plan.
Comments, committee? Seeing none. I'm looking for shaking heads out there. I believe that would be acceptable. So, all in favor of Senator Hutchings' motion to amend line 21, page 2, say aye.
Aye.
All opposed, say no. That amendment passes. Further amendments? Senator Dockstetter. You're not on.
I fully.
You're on now.
On page 3, on lines 1 through 3, I see the, patient care team shall develop a plan of safe care in cooperation with the infant's parents or guardians. And I fully respect that the testimony was given today, people traveling in and testifying that there may be a bigger picture there. But under our legal wording, take it beyond a parent or a guardian. I'm not sure that we can do that and still be as effective. Because who do we take it out to? Family, additional family, appointed guardians. I don't, I'm just not, I guess I'm not quite ready because I don't want to cause a problem with the legal world in that, but I hear the concern.
I would agree with that. Go ahead, Senator Bouchard. What I was gonna say is I think that's something perhaps the attorneys in the floor and et cetera, because I have a feeling that's more of a legal question than a medical question. And yeah, like Senator Dockstader, I could see that it get extended out to grandparents, cousins, et cetera. And it may become problematic in the legal world. I'm not a lawyer and I didn't stay at Holiday Inn Express, so we'll leave that one alone now. Senator Hutchins.
Well, I want to revisit it though,
Okay.
Mr. Chairman, because I think it's important, because we're just saying here in your paragraph B that the patient care team shall develop a plan of safe care in cooperation with the infant's parents. And I don't see a problem with adding or family members, parents, family members, or guardian, because when the woman leaves the hospital with the child and that plan of safe care, it's going to be important for the family to be involved in it. So if we just say family, and if the lawyers on the floor disagree or if someone has a problem with it, maybe we can take that out. But I think it's so important that the family is involved in this plan.
How would you feel about the wording if it said this, Senator Hutchins, and this just suggestion was said in cooperation with the infant's parents, comma, families, comma, or guardians?
Spot on.
Would you like to propose that amendment?
I would like to propose that amendment, Mr. Chairman.
Discussion, Senator Dockstader.
I support it, but I know our legal will. Family.
Let's see what
Your aunt
happens.
by marriage, second cousin, who? It's, I'll support it in general, but,
That may be a discussion we hear on the floor.
We
Yeah.
need legal counsel, but
Yeah.
I'll support you.
Thank you, Mr. Chair. Thank you, Senator.
And you've heard the motion. Any further discussion on it? I think we'll put it forward as a standing committee amendment. We'll have that discussion on the floor, and if we wish to change it, we'll. Go ahead, Senator Bouchard.
Just a comment, obviously I'm not a lawyer, but it's vague enough where I don't think it'll have a legal challenge. I mean, we're not saying grandparents or parental rights, affecting that, so.
Very good. You've heard the motion to amend page 3, line 2, as noted. We get that language? Yeah. Very good. All in favor of that amendment, please say aye. Aye. All opposed? No. That amendment passes. Further amendments committee. Senator Bouchard.
Well, I want to make one little comment about what we just did. So I think we're actually putting this together so they make rules. So we're not making statute that is going to be directly in a challenge. We're kicking the ball down the court to them. They're going to make rules. And so I think that will get handled there. The intent is we want the family unit, right? And so now we'll bring it to my amendment. So I just want to have an emphasis of what we talked about with keeping the mother and the baby together. So I would feel better if we had something probably in section 1 where it said, the safe care plan shall place top priority in keeping babies and mothers together. Because I think in the rulemaking, all we're doing is telling them what our intentions are. So that would be my amendment.
Okay. Did you propose that as an amendment?
Yeah, I would do that in section 1, and I believe.
Which page are we talking? Page 2?
Yeah, page 2. So want me to read it again?
Go ahead and read it. Tell us the line.
The safe care plan shall place top priority in keeping babies and mothers together.
Are you talking line 14? Where exactly?
I would put it in a standalone, just so it's.
Oh, okay, I got you. So go ahead and read that entire section if you would to us.
You mean read the amendment again?
Yeah, read the amendment with that, just put it in the context of that whole paragraph
Page
there. if
and
you would.
line again, please.
Well, I'm just, what I'm saying is just, its own numerate or numbering in here. And so I would let them draft wherever they want to put it. So I'm not saying specifically where it has to be, just in section 1, page 2, with its own numbering. And then just stand alone where it says this, the safe care plan shall place top priority in keeping families, I'm sorry, keeping babies and mothers together.
Mr.
Senator,
Chairman,
go ahead, Senator Dockstader.
I see what you're trying to do. I think that would be tough to defend on the floor unless we had it actually written in what line, what you're going to do specifically for wording.
How about if we do this, Senator Bouchard? How about if you work on that wording, perhaps get with the department as well, and come up with a committee of the whole amendment?
Yeah, I think that's
And we'll present it that way.
And then we,
Mr. Chairman, if I'm trying to throw this out there and let you look at the bill and tell me where you would think you would put it. Because remember, this is all back to rulemaking. We're suggesting what this plan is going to be. We're not actually writing anything in stone here, but we're suggesting a priority of what this whole plan is to look like when they write the rules.
And I hate long sentences, but I can tell you, if I was going to put that into the bill in section 3, little I, and I really hate long sentences, so there's probably a better way to do it. I would put as well as to maintain the family unit as much as possible, or something to that effect.
I'm a little uncomfortable with that vague wording at the committee level. I would suggest a committee of the whole amendment specifically written with legal counsel.
Yeah, I guess I would.
Mr. Chairman, I liked what you just said. I mean, can you amend my amendment?
Well, you haven't formally moved an amendment, so you can, if you want to make that amendment, that was just to put it at the bottom.
Where would you put that?
Triple little I, line 19.
What about after or in line 15, after the word infant? Because I see where he's going.
I think that probably makes the sentence even more confusing.
It will be long, yeah.
And that will get shredded on the floor, I'm afraid.
Safety will.
I think at this point, and I agree with Senator Dockstader, is if we can come up with something before committee of the whole, put a committee of the whole amendment together. And I would suggest perhaps it's its own paragraph, if we put that language in.
Mr. Chairman, that's how I see it, as one of where the Romanettes are, is have it stand alone.
What I would propose is that you put together a little I, and we just renumber it, but just put that together as a committee of the whole amendment. I think we could defend that on the floor, but I think it will be better as a committee of the whole amendment rather than put it in here. If that's
what
all right.
I would move that we do that, number it in that section 1. That's what I
Okay,
originally said.
Okay, just go ahead and give us a wording and we'll formally vote on the amendment. Just throw in the wording.
Okay, so the actual wording is the safe care plan shall place top priority in keeping babies and mothers together.
Okay, and we would throw that in as a little Romanette 4 in that case. I.
4 would be fine, yeah, on page 2.
Right, and yeah.
Gotcha.
So that's the amendment proposed. All those in favor of Senator Bouchard's amendment as proposed, please say aye.
Aye.
No, say no. No. So that amendment has not passed, that amendment has failed, but I do suggest that come back as a committee of the whole if you can get that written. Anything further, committee? Okay, let's vote on the bill.
Thank you, Mr. Chairman. Senate File 79, Plan of Safe Care Newborns as amended. Senator Barlow.
Senator Barlow left an aye.
Senator Bouchard.
Aye.
Senator Dockstader.
Aye.
Senator Hutchings.
Aye.
And Chairman Bouchard, or Chairman Baldwin, sorry.
Thank you, Senator. Senate File 79 has passed the Senate Labor and Health Committee. And our senator who is anxiously awaited back there impatiently, Senator Ellis, welcome to our committee. We don't get to see you often, but we appreciate you when we can. Go ahead. Why don't you go ahead over and check while she presents a bill to us? And then just let me know. Okay. Okay. Oh. Thank you. So the next bill that we're going to hear is from Senate File 94, Federal Indian Child Welfare Act Codification. And to present this bill to us is Senator Ellis. Welcome, Senator Ellis.
Thank you, Mr. Chairman. Before I begin explaining what's in the bill, I want to provide some context of why it's important and hopefully explain why it's important for this bill to pass this session. To do that adequately, I need to take you back in history a little bit. And for those of you who are unfamiliar with Native American policy and the development of our laws over the last couple of centuries, there was a period in our country where it was really the policy of the federal government to kill the Indian and save the man. As more Westerners started taking over, the entire country, the initial philosophy of the government to just push Indians west through efforts and things like Trail of Tears were really becoming strained. And it became apparent that the federal government would need to do something with what they referred to as the Indian problem. And so in doing that, they recognized there were tension and conflicts between Native peoples and non-Indians. And so their philosophy was a simple one. Rather than exterminate these individuals, it would be to assimilate them into white society. And so there were a number of policies adopted in the 1800s with that goal in mind. One of them was called the General Allotment Act, and basically took reservations, divided them into small individual Indian allotments, and assigned those to eligible Indian male heirs. And the theory was to break up tribal communities and try and turn these nomadic Indian people into farmers and ranchers. What ended up happening was a lot of the excess lands were made available to non-Indians. It resulted in the loss of about 100 million acres of tribal land base. And it wasn't until 1928 that a federal report came out that's often referred to as the Merriam Report, which found that the assimilation policies had failed. Indian people were living in poverty, their social structures were wildly disrupted. And so in 1934, Congress responded by passing the Indian Reorganization Act, which stopped allotment. Also around the same time, there was an effort by our government to require Indian children to attend boarding schools, often far away from home. And so there are horrific stories. There was a school opened in Carlisle, Pennsylvania, and the goal was to place these children in these federal schools operated by the federal government. They were punished for speaking their native languages, for practicing their culture. Their hair was cut, and hair is very symbolic and important for a lot of Native societies. There were cases of abuse, and many children were never returned home. Last year, you may have read about a recent story of a boarding school in Canada where an archaeologist found the remains of 200 Indian children who never made it back. Our tribe, one of our tribes, the Northern Arapaho tribe, has been very involved in trying to repatriate some of the remains of their children back to the reservation so they could be properly interred and have the proper ceremonial burial. So although we speak of these things as though they happened hundreds of years ago, I can tell you that Indian boarding schools was going on well into the 1900s. Both of my parents attended a boarding school which was designed for Navajo children. It was open in northern Utah. It started in the mid-1950s, and that school didn't close until 1984. My mother had attended a different school prior to that, where she was severely mistreated. And quite honestly, Mr. Chairman, I have difficulty even talking about her stories. So these were very public initiatives initiated by our federal government to assimilate Native people into non-Indian society. But states also had a very heavy hand in that as well. Throughout the 1900s, studies revealed that many Native children were being separated from their families, their parents, and their communities by child welfare adoptive agencies. So specifically, 25 to 35% of Native children were being removed, and of these, 85% were placed outside their families and their communities, even though there were willing relatives who were available to provide care. The 1970s was an important era in federal Indian law. President Nixon declared that time to be one of self-determination, to try and restore tribes, tribal rights, tribal government rights, and really provide more support for culture. So through that lens, Congress passed the Indian Child Welfare Act in 1978 to further stop Native children from being separated from their parents, their extended families, and their communities. So for the last 45 years or so, we've operated under the Indian Child Welfare Act, but in recent years, there have been challenges to that act. Right now, pending before the U.S. Supreme Court is a case that we refer to as Brackeen. It's a consolidation of 2 other cases as well, and it's a challenge to the Indian Child Welfare Act on 2 grounds. The first one involves something, and I'm just telling you this so you know the full gamut of what's out there. Under our federal constitution, we can't make laws that prefer one race over another unless you have a compelling government interest. And so, for an example, you can't say, to right the wrongs of the past, we want to provide African Americans with a preference in job hiring. However, Native Americans are different. Because of our history, the fact that these are sovereign nations and your membership in tribe is what we refer to as a political one, you can actually provide a hiring preference for Native people. And in fact, the Department of Interior does that within the Bureau of Indian Affairs. We do that in Wyoming. We provide preferences because of your status of being a Wyoming resident, which has nothing to do with your race. However, there is confusion. Sometimes Indian people are actually able to utilize some of the race-based arguments. And so that's one of the challenges, is that the Indian Child Welfare Act is an impermissible classification of race. So that's one threat. The second one, and this is actually what I think is more important to focus on, is the fact that Congress is one of limited powers. And usually there are things that are powers reserved to the states. Those things are policing power, family law, and education are the 3 big examples that come to mind. So there are arguments pending before the court that would say that Congress has exceeded its power through, things like a 10th Amendment anti-commandeering argument, Congress's authority under the Indian Commerce Clause. And so that could actually threaten the ability for Congress to pass and maintain the Indian Child Welfare Act. In thinking about this during the interim, both of our tribes have requested for us to adopt and codify the Indian Child Welfare Act into our state law. After a lot of consideration in the interim, I decided that it was important that this session we address this important concern. If Congress invalidates ICWA based on the political classification discussion, all of federal Indian law will be unraveled. It will be a huge departure, and one that's bigger than we can imagine. So I'm not a gambling lady, but if I had to guess, my hope and prayer is that that remains intact. However, on the overreach of Congress's power, we might see an instance where the court accepts those arguments. If that happens, then states would be allowed under their authority to provide certain protections, recognizing the sovereign right of tribes to impose their own ICWA laws. And so that's what this bill intends to do. It would simply codify the Federal Indian Child Welfare Act. So we'll walk through the bill and what that is. I know we're not really supposed to talk about what happens down the hall, but there is a companion bill that would require set up an Indian Child Welfare Act task force. Other states have been doing these task forces, implementing their own laws, working with their tribes to more, meet the needs of their particular states. So that's an important companion bill to this effort. I think the thing that's concerning me, though, and why this is important now, is if we have a Supreme Court decision that comes out sometime this spring or early summer that invalidates ICWA, we'll start asking, well, what next? What do we do with these Indian children? Should they be in state court proceedings? What notice requirements? If we maintain the status quo, there's really no authority for that. So if family were to, challenge the proceeding, it just creates confusion. And we can't afford to have confusion when it comes to these cases because they involve placement of children. This is very serious stuff. So this, Mr. Chairman, would act as a stopgap for that. It would allow the status quo to remain in place. Then in the spring, we would see what the court does. If the court does nothing, we have a book on our laws that reflects what the practice is right now. However, if there's a huge disruption, at least then we've got something in place that we can start working off of to make sure that these kids are not falling through the cracks. So with that, pages 1 through 5 provide several definitions: child custody proceeding, extended family member, Indian, what constitutes an Indian child. There, I would note that that definition includes the member of a tribe or a child that is eligible for membership. The definition of an Indian child's tribe: Indian custodian, Indian organization, and Indian tribe. For the definition of parent, you'll see that it includes the biological parent or parents of an Indian child, or any Indian person who has lawfully adopted an Indian child. You'll see a definition for reservation as well as one for shelter care. Here we made some conforming amendments to make sure that we were referencing an existing definition in Wyoming statute found in Title 14.
Senator Ellis, I think we have a question real
Oh,
quick.
yep, Senator, Mr. Chairman.
Mr. Chairman, thank you. Senator Ellis, I don't want to interrupt you, but I have got lots of notes. And do you mind if we do interrupt you as you're going along? I don't want you to move so fast, but I want to ask questions when we're there. Is that okay? Or would you like to just go? It's up to you.
Maybe we can go through the overview and maybe that'll provide the context because
Thank
it
you.
is kind of a quirk. It's a big bill.
It's huge.
It's a huge bill.
Thank you, ma'am.
Very
So
good, proceed.
the thrust of the Indian Child Welfare Act, though, really begins on pages 6 and 7, and this talks about who has jurisdiction, and it discusses notice requirements. So here it clarifies that tribes have exclusive jurisdiction over any child custody proceeding involving Indian children domiciled within the reservation. We should be familiar with that. We've talked about that in terms of the absenteeism laws. If the tribe lives on the reservation, the tribe has exclusive jurisdiction. If an Indian child, however, is domiciled off the reservation and there's a state court proceeding involving the placement of that child or the termination of parental rights, paragraph B on page, let me see, I think it's 6 or 7. 6 describes the process of how the state court is required to transfer that case to tribal court if a parent or guardian, or excuse me, parent or custodian petitions the state court. Page 7 talks about if there's a state court proceeding, paragraph C will provide the child's tribe a right to intervene in that state court proceeding. So there are instances where these proceedings do occur in state court as long as notice requirements are met and the Indian child's parents consent to that jurisdiction. Lines 11 through 16 on page 7 clarify that Wyoming will also give full faith and credit to tribal court orders. Page 7 through 10 covers matters with involuntary proceedings in state court. Here you'll see provisions that provide a duty to notify parents of their rights to intervene. And if the state court finds that an Indian parent or custodian is indigent, the court shall appoint counsel for shelter care placement or termination of parental rights. It also talks about the rights to examine reports. And then on to page 9, it talks about the burdens of proof. Here, courts will have to provide clear and convincing evidence for custody matters. But if the case involves a termination of parental rights, the standard used is reasonable doubt. That is one of our highest legal standards. Page 10 covers matters involving voluntary placement. The others were involuntary. Here, the goal is to ensure that the Indian parent who consents to any placement or termination of the parental rights fully understands what's happening. It allows parents to withdraw their consent before any final decrees of termination or adoption are entered, and it allows an Indian parent or custodian to invalidate an action if a court of competent jurisdiction found that a state court violated provisions of this law. Pages 12 through 15 talk about the preference for placement of children. Here, the first preference would be to a member of the child's family, second to other members of the Indian child's tribe, third to other Indian families, and then fourth, any other placement. However, it also recognizes that tribes may adopt a different placement through their tribal code and their tribal ordinances, and that it also has a duty for courts and family service agencies to keep records of each placement of Indian children so they don't slip through the cracks. Begin on page 15 through 16, you'll also see some more miscellaneous provisions. And now my notes are out of order. 1 second. Page 15 and 16 deals with the return of custody if there's a final decree of adoption that has been vacated. Page 16 and 17 talks about when an Indian child reaches the age of 18, that person may receive information about their tribal affiliation. Page 17 is a cool page, which maybe is a direction we're headed. It talks about agreements that may be entered into between a state and tribes concerning the custody and care of Indian children. Page 18 provides remedies for improper removal of Indian children and also clarifies that if there's any applicable federal law that provides a higher standard of protection to the rights of an Indian parent, that a court should provide that higher standard. Page 19 clarifies that nothing in this act should be construed to prevent the emergency removal of an Indian child to prevent imminent physical harm or danger to that child. And then as we're winding up the last sections of this, page 20 through 22 talks about the required reporting information about state court proceedings involving adoptions, the Department of Family Services and the U.S. Secretary of the Interior will need to receive that information. Page 22 provides the Department of Family Services with rulemaking under this new act. Page 22 through 31 are largely conforming amendments. Title I is your civil procedure title. Title 14 involves your children, that's our children's code. Child 20 deals with domestic relations, and then Title 21 talks is your education the education title. That's involved because sometimes when a student is absent, it might be a sign of child neglect and could lead to termination of parental rights or other placement. So finally, page 31 would authorize the Department of Family Services to immediately begin their rulemaking. I want to conclude by saying that both tribes support this bill. I have a letter of support from the Eastern Shoshone, which I failed to print off and provide you, but we'll do that within when I get back to my desk, if that's something you would like to see. And then the Department of Family Services and the Attorney General's office had asked for a few clarifying amendments, so I provided those to you in written form. The first ones, I walk through these and I think they're clarifying amendments. We can walk through those at some point if you'd like, but they're pretty straightforward. I'd also add that maybe to ensure that there is no gap in coverage, that maybe instead of having this law take effect on July 1st, maybe it take immediate effect. And then one other drafting convention is on page 2, line 14. The federal law uses the word and. Our drafting conventions, I think it's more appropriate to use the word or. So those are things for you to consider when you start working this bill. But with that, thank you for your patience, Senator Hutchings. I know it's easier to ask as you go. But I wanted to also just convey that in requesting this bill draft, I asked LSO to really codify the federal law, not to place any of our preferences, our things that we think how it should work in this bill. This really is an attempt to codify the existing framework that we have in place. As I mentioned, there is another effort underway that would allow the state to work with our tribes to see if there are other areas in here that we could maybe improve on and make better. But at this time, I don't think that those recommendations are appropriate. They just haven't been fully vetted. Happy to answer any questions.
Very good questions, Senator Hutchings.
Fast, thank you. Took me a while to read this bill, and you went through it very quickly, and I appreciate your history. And as a Black woman, I would agree with you that our history is totally different from the Native history. And I don't think people realize that. We were people that were kidnapped, sold, brought over here, and used as property. Our natives were, like you say, exterminate or assimilate. And when I read our history, the Trail of Tears, is it? Incredible. I don't think any of us went through that. So again, I agree with you. Our history is different. Yours is important. You're here. We've assimilated, I hope, as best we could. I want to ask on page 6, I think it is. Let me make sure. I'm having trouble with page 3. And I think you've answered it, why you bring in the Alaskan Natives, because you're bringing in the federal law. Is that the answer?
Senator Ellis.
Thank you, Mr. Chairman. Yes. So this is a all-encompassing because of these removal policies. My tribe is Navajo. That tends to be Four Corners area. But because of these Indian boarding schools, my parents both received an education in northern Utah. My dad found work in Wyoming, and that's how you have Navajo people who grow up in Jackson, Wyoming. And my dad was a welder. I just thought I'd throw that out there. But this covers not just tribes within our state. It really is any, and people move. We're a very mobile society.
Right.
The rights of the tribes are preserved, and so we do want to be inclusive that tribes are included in that, or Alaska Natives and tribes across the country, any federally recognized Indian tribe.
That's sweet. Follow up, Mr.
Further, go
Chairman. Just an FYI, I am proud to say the first 3 children that I fostered in Alaska when I lived there were natives. I said I didn't want children that were Black only. I want all races to foster. And the 3 kids that I fostered are now all in their 30s. So that was a wonderful experience. When we get to page 17, you mentioned when a child reaches 18, My question there is, and I think it goes on to where you talk about the Department of Interior. Are we trying to notify the Department of Interior a child's being removed from a tribe, put wherever, so when they turn 18, there's a way for him to go back because a parent may not allow them to be notified when they're 18, but the Department of Interior can tell that child what tribe they're from? Is that what's going on there?
Senator Ellis?
Thank you, Mr. Chairman. I believe so.
Okay, thank you.
And really an effort to make sure that there's no efforts by states to hide these proceedings. So duty to report, and the Secretary of Interior is in charge of, there's a, organizationally, that's the primary agency that provides services to tribes. But there are, within each other agency, the Department of Justice, Department of Health, they all have like Native American offices.
Gotcha.
But Department of Interior is the primary agency, the department.
Okay. Further questions, committee? Seeing none. Let's see if there's any other testimony. I know we've got a couple of people online, or they've registered earlier. Is there anybody?
Mr. Chairman, one last thing.
Oh, go ahead, Senator.
The Attorney General's office and the Department of Family Services had one other request for an amendment. I felt it maybe looked a little too dissimilar from the original act. So I would like to reach out to our tribes, provide them with that suggestion, get their feedback. And so you might see a committee of the whole amendment if I can get that consensus pulled together.
That would
Just
be
a heads
great.
up for
Thank
you.
you. And I would invite you to hang around. We'll allow you to participate in the amendment process as well. Go ahead, sir.
Thank you, Mr. Chairman. My name is Travis McNevin here on behalf of the Northern Idaho Business Council. I would simply like to draw the committee's attention. We have co-chair Karen Returns to War and the in-house legal counsel Claire Johnson waiting online, and would like to introduce them and ask for the committee's indulgence to admit them for testimony.
Let's go ahead and admit them both in. With the knowledge that we'll try to keep his testimony brief if we can and not make it extended, so we can get this bill voted on and hopefully get it moved ahead today. Okay, they're admitted. We have Karen and Claire. If you can hear us, Karen and Claire, go ahead and make sure you turn your audio and your video on for us, please. And there they both are. Welcome to Labor and Health this morning, ladies. I don't know if it's snowing where you're at, but we all had to go. Oh, okay, we'd all like to be where you are because it's snowing here. If you'd like to go ahead, Karen, lead us off and tell us what's on your mind.
Okay. So good morning. I just want to address you. Good morning, Chairman Baldwin and the rest of the committee there. I don't know you all by name, so I don't mean to be disrespectful. So I just want to introduce myself in my Arapaho language first off. So dos to everybody. Good say. My English name is Karen Returns to War. My Arapaho name was given to me by my dad, and it comes from his mother, which is Sitting Woman, which a lot of people are saying is appropriate. So I am here today in support of this bill. I'm grateful for Senator Ellis for reaching out on behalf of the tribes and being proactive on behalf of both the Northern Arapaho and the Eastern Shoshone tribes. I just want to speak to you from a I'm personally invested in this ICW, and it touches really close to home for me. I have 2 older sisters and older brother whose children was adopted out. Fortunately, we have one of the oldest one, my oldest niece has found us now. We still do not know where the other 2 are. Back in the early 1970s, social services was still being run by BIA. It was and I think we all know what BIA's policy was about assimilation and removing children from the environment, from their families, from our culture. And So basically, that was what the social worker, her intent was. My sisters were both really young at the time they had to make those decisions, and they were very much encouraged by the BIA social worker to adopt them out. We know for a fact now that the oldest was adopted by a non-native family. Her mother was German. She didn't say what descent her adopted father was, but she was raised in Alaska. Although she never had no ties to the Northern Arapaho tribe, her adopted mother did try to give her books and just, that kind of knowledge about where she comes from. And she was always told that she was Native American, Northern Arapaho. But she learned a lot of stuff from the Alaska natives. So she had a lot of ties there. Back probably 5-6 years ago, 5-6 years ago, she found us. She was able to find us again, and that really helped. My older sister, she was really overwhelmed, and I just want to mention that she's no longer with us. I talked to my other older sister, and both of them have said that they regret making that decision. They regret going along with the social workers' recommendation to adopt their children out. That they both have wondered where their children were they safe? They don't know, and they were no longer exposed to the language, our ceremonies, our way of life, our traditions, everything that makes us as Arapahoes, who we are. One of the things that my niece has told me that really impacted me and basically says it all. She said, she's really glad that she found us. She found her family because she never experienced the love that she has been getting, the family support and the conditional love ever in her life until she found her family again. I feel that's really important. I just want to end with a statement that the Mississippi Band of Choctaws has put out there. And, they say children are tribal communities' most valuable resource. Since the language, culture, and traditions that make these communities unique are passed down from generation to generation, that there clearly states every reason why that we need to make sure that our tribal communities, our tribal people continue to surround our own children and have say in what happens to them. I thank you for your time.
Thank you very
I'll
much.
turn it over to our tribal attorney, Claire. Thank you.
Very good. Claire, welcome to our committee. Go ahead, ma'am.
Good afternoon, Chairman Baldwin. Can you hear me?
We can hear you perfectly. Go ahead.
Perfect. I just want to reiterate that the Northern Arapaho tribe thanks Senator Ellis for bringing this bill forward. We feel that it's
We lost your audio. I'm sorry, Claire.
okay. Is
Okay.
it back?
You're back.
Okay. The Indian Child Welfare Act was put into law to protect the healing from generations of family separations that target Native people, specifically children. It was widely considered to be the gold standard in child welfare policy because the law places children within the extended families and within their community, which is best practice. We are very, very concerned about a Supreme Court decision to come out because even under ICWA right now, Native children are 3 times more likely than their non-Native peers to be removed from the home. We believe that Senator Ellis's efforts to codify the federal law within state law will help keep the status quo, help keep a system that's working in Wyoming, that's working for the tribes going. And we just want to once again reiterate our strong support for this bill and our strong support for the bill down the hall on the task force to consider other improvements that could be made as well. So thank you.
Thank you very much for that testimony. I believe committee will close public testimony with that unless there's somebody in the audience with a burning desire. If you can make it quick, sir, please, so we can get this. Both of you can come on up. We have lots of chairs. There's plenty of room. And if there's none others after these, we will close public testimony after these and get the bill moved and taken care of. Go ahead.
Mr. Chairman, my name is Corin Schmidt. I'm the director of the Wyoming Department of Family Services, and we appreciate the effort to bring this bill forward. And mostly, I'm just here in case you have any questions.
Thank you. Any questions for the director? You're off the hook today. Don't expect it every meeting. Go ahead, sir.
Good morning, Chairman Baldwin, members of the committee. My name is Kit Wentland, Special Counsel and Tribal Relations Policy Advisor for the Governor. Just wanted to state the Governor's Office does support the drafting of a state ICWA law, participating in the task force that's going on down the hallway, considering all the disruption that could be caused by the Supreme Court case. As ICWA could have such a significant impact on tribal communities, the ability for the tribes to have a voice in that process we feel is important. So that's the sum total of my comments. Thank you.
Very good. Any questions, Quinny? Seeing none, thank you. Senator Ellis, would you like to come back up to the table with us?
Move the bill.
Committee, move the bill. Senator Barlow moves the bill. Comments on the bill, amendments? Committee or Senator Ellis, I believe we have that amendment, a couple of amendments in front of us here. One piece of paper, 3 amendments, I believe.
Yeah, Mr. Chairman, if you would start looking at page 11, I will walk through how about the entire suggestion. And then if that speeds things up, actually, let's back up to page 2.
Great.
Page 2, line 14, here you'll see that the definition of child custody proceedings includes shelter care placement, the termination of parental rights, pre-adoptive placement, and adoptive placement. The federal law uses the word "and," but our drafting conventions, I would think it'd be clear to use the word "or." That's how I believe we draft such statutes. I think it's consistent with what the federal act intends to do. Then going on to page 11, line 9, the suggestion would be to terminate, or excuse me, on line 9, delete the word termination onto page, or line 10, termination of parental rights to or adoptive placement of. Instead, use the word relinquish and consent to adoption of. In Wyoming law, we don't have voluntary termination of parental rights. The term used is relinquishment and consent to adoption. Page 12, line 8. This is a clarifying amendment. It would say, instead of if an Indian child is the subject for foster care placement, it would just simply say any Indian child who is the subject of any action for shelter care placement. That's language consistent throughout this act. Page 14, line 19, there was a typo there. We meant to refer to section 705 rather than 706. Page 16, line 8, after the word further, just adding that word shelter care so it's clear. Page 19 through line 11. After the words child in, insert the words temporary protective custody or shelter care. That's a catch-all to just make that clear. Page 27. This is language that's in existing Title 14. Right now, we don't notify the tribal court. There's actually an ICWA designated person by each tribe, and so the notification's to the tribe, and they can designate or provide a designee, and they usually choose that ICWA coordinator, for lack of, I don't remember the exact terminology, but those would be the clarifying amendments. And then the final suggestion would be on section 5, rather than waiting for July 1st, just that this law would take immediate effect.
Very good, and I believe staff has all those. Correct. Okay. Comments on the proposed amendment, committee? Oh, Senator Hutchins.
No. We'll wait for the bill.
Okay.
Thank you.
Okay, well, we're working the bill. The bill is moved, so comments on the bill or add, and somebody want to move this amendment?
Move the amendment.
Yeah.
Entirety.
Amendment is moved in its entirety by Senator Barlow. Any discussion? Seeing no questions, all in favor of that amendment as proposed by Senator Barlow, please say aye.
Aye.
Aye. All opposed, say no. That amendment passes Further on the bill committee. Senator Hutchings.
Mr. Chairman, I know you were allowing Senator Ellis to be in on the conversation on the amendments. Question on the bill. I remember in the past, there was an issue with law enforcement on the tribes. And then later on, if I believe this is true, if I have it right, there was an issue with the tribes being able to keep up with the law enforcement. So I'm wondering, is there anything in this bill that you think the tribes will have trouble handling?
Senator Ellis.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. No, this will just maintain the status quo of how things currently operate.
Gotcha.
Very good.
Thank you.
No further amendments or questions, committee? Call the question on the bill. Let's do the vote, please.
Thank you, Mr. Chairman. Senate File Number 94, Federal Indian Child Welfare Act Codification. Senator Barlow.
Aye.
Senator Bouchard. Senator Dockstader stated aye. Senator Hutchings.
Aye.
And Chairman Baldwin.
Aye.
We have 5 ayes.
Okay, that Senate file is passed the Senate committee. Thank you very much, everyone.
27.
And thank you very much, committee. Good job.
Thank
Let's
you.
go